in lower risk MDS, it's now quite clear that a really central pathogenic determinant of the disease is what is called inflammasome activation. And essentially, it probably gets activated through multiple mechanisms, including the underlying somatic mutations, the bone marrow microenvironment through myeloid-derived suppressor cells, but ultimately you get this NLRP3 inflammasome activation. And actually, just if you look at components of the pathway, such as ASC specks, which are formed during this process, or oxidized mitochondrial DNA, which can trigger this process. This can actually be relevant even in cases of diagnostic uncertainty. So if you look at low-risk MDS versus normal, or low-risk MDS versus high-risk MDS, or other malignant hematologic neoplasms, both are very, very sensitive and specific for the diagnosis, and so they can be helpful. And they may actually be able to even predict outcomes to lower risk therapy. So for example, we recently published data when we look at the outcomes to lenalidomide and ESA in lower risk MDS patients. And if you had high ASC specks and low EPO level, that was the highest chance to respond, actually almost 70%. Whereas if you have the opposite of having a high EPO level and low ASC specs, actually no patients responded. And this was data from the phase 3 GFM Len plus ESA study. So I think we really know that these pathways are really important. And I think to date, all of our therapies are really solely focused on anemia improvement, which is critical for our patients, but is not disease modifying, leaves out patients with other cytopenias. And so thinking about ultimately changing the natural history of the disease, or even thinking past that, can we prevent patients, let's say with CHIP or CICAS, from even developing myelodysplastic syndrome, given these processes are important, I think is a real future clinical strategy. And so targeting multiple steps is actually now starting to become a reality. So we have, as well as MD Anderson has clinical trials with Canakinumab, which is an interleukin-1 beta monoclonal antibody that inhibits it. And that is sort of the end cytokine in inflammasome activation. So that's one process. NLRP3 is really the central key driver of all of this. And so there are specific NLRP3 inhibitors that will be entering clinical trials sort of late this year, 2022. And then maybe there's combinations. Maybe you have to, because multiple different pathways may ultimately lead to inflammasome activation. IRAK4 may be relevant, NLRP3, and other steps, interleukin-1 beta, as we talked about, TGF beta, and then, or could this just be combined with other lower risk therapies? I think there's a lot of possibilities, but I think that's the real goal, is to think about truly changing the natural history of lower risk MDS, coming up with therapies that really may target the underlying MDS pathogenesis. So I think we're excited to at least start to investigate that in the near future.